Welcome to the EMT Pro podcast, where we deliver relevant EMS content from the field in the classroom each month. Episodes of this podcast can get you 1 full hour of CE through our partner, emt-ce.com, so head over there for more information. I'm your host, Steve Williams, and with me today is Dan, Holly, and Ramsey. Guys, say hello.
Hello there.
Hello.
Hello.
And Holly, you're remote today, calling in on this one.
I am.
Yeah, so
I
it's
am.
like our guest, but
I'm
you're
your
not.
guest.
You're kind of like the guest.
So
as
that
well.
means you have
our
to be
guest.
nice to me if I'm your guest.
Yeah,
That's right.
yeah, we're always nice to you.
Can't even
It's
tell
Dan that
you're-
we're never very nice to.
you're-
That's right. That's right.
Did I just admit that? Yeah, dang it.
I mean, your service sounds great when Dan calls in.
Yeah, it's like he's in some
He's
remote
like in the-
town. Didn't even think that he might have a bad cell area. Yeah.
Oh,
I thought you
wow.
were stuck on the International Space Station
Was it that
last
bad?
time. Goodness.
Oh, wow.
That one took a lot of editing. Yeah, I'll just say that. Cool. Well, we got a fun episode today. At least I think it'll be fun. I've got a couple case reviews I want to throw at you. Definitely want to get Ramsey's take on it. And want to also hear about your other exposures to these types of calls and see what you guys think. So I'll give you the info of what we're talking about today after the first case review. And then I'll share a second one that was very similar. And then would love to hear your guys' experiences with them too. But want to just get started?
Let's do it.
Let's
Cool.
do it.
All right. So I'll give you all the information you ask for, and Dan, maybe you lead, kind of the questions that you would want to know from an
Okay.
EMS perspective. The dispatch info is ground level fall. We're going to a neighboring jurisdiction in our ambulance. I work for
So
fire-
longer transport time?
Yeah, transport time is going to end up being about 25 minutes.
Oh, okay.
The area that I work in has the ambulance service agreement for the county, and so that includes a bunch of smaller departments
Okay.
around our town. So we're dispatched for a ground level fall, and when we get there, we're staged. So the QRTs have basically said, we got this. We've been to this address before.
Just hang out.
Just hang out.
Okay.
So we're sitting in the ambulance waiting to be canceled. So
Yeah.
that's the mentality.
Thinking about dinner.
Yeah. What's I should tell you the time of day because it was exactly right around 5:30 at night.
Okay.
So we had dinner being, in the process.
Right.
It was high on our list of to-dos. And here we are staged on scene outside of a let me describe the house for you.
Bring me there.
So we're kind of in this alleyway of sorts, but down the alleyway, it was like I feel like other countries have them a better way to describe them, but they're like a half street. You ever heard of that term?
No.
So it's
No.
basically like an alleyway that has really small, tiny houses down the side. And
Oh,
they're
okay.
like,
I know what you're talking about.
yeah,
Yeah.
they're like they don't have an actual their street address is off of the street
Yes.
that this little alleyway
Yep.
or
This is a Hogwarts reference.
yeah, I mean it's Hogwarts. Right? It was like
Actually Hogwarts.
what was the
It's
what
Harry
was the
Potter.
Yeah,
Yeah.
39 and a half. Was that the
You're at Ollivander's, the wand shop. You're at the wand shop.
Gryffindor.
Okay,
Yeah.
perfect.
So we're staged out on the street. We end up getting waved in, kind of like this person comes out. I'm trying to remember what his level of provide. I think he's an intermediate. Comes out, kind of flags us down. Says, just come in and let's have a quick chat. Okay. So I'm not really sure what the heck that means.
Yeah.
but
You're already disappointed because dinner's
Yeah.
getting cold.
yeah. We're like, how much longer are you going to request that we stay here?
Right.
So walk in, and this is like these units are like a studio apartment, and there may be a total of about 350 square feet.
Okay.
The living area butts up against a very small kitchenette. This lady has her bed in the, kind of the central part of the house, I guess you would call it. Entertainment area, TV, nightstand, kitchenette, table, and then the house is kind of in disarray. And having, 4 or 5 QRTs plus
Yeah.
our 3-person ambulance is a lot. So, patient is on the bed, and she's talking to the QRTs. I'm going to guess she was probably about 72-ish.
Okay.
Smaller gal.
Okay.
Maybe 5'3", 5'4", and about, I'm going to guess 110, 120 pounds max. She's there with a, what we thought was daughter, ends up just being a neighbor. Doesn't really matter though. And she's a friend who takes care of her, watches her. And she goes, yeah, she just keeps falling. She won't stop falling. We're like, okay. Talking to the patient, and she's like agitated that we're there.
Yeah.
And just kind of wants us to leave. So at this point, I'm kind of wondering, hey, when are they going to cancel us? Because like she doesn't want us here. And
How did she look when you just looked at her?
so patient presented, she was in regular clothes, appropriate for the time of day and the season. And she had she looked a little pale, maybe.
Okay.
A little pale. She wasn't, complaining of much, but she couldn't, I guess her chief only complaint was she couldn't get comfortable.
Oh.
So she was like, I would guess a good word would be like agitated.
That's a bad sign.
Yeah.
Mhm.
Always
Yeah.
a bad sign.
So it was. Here we are talking about it on podcast. So we're asking her about the falls because she said she had fallen earlier in the day, was feeling weak, and she thinks she hurt her rib on her left side.
Okay.
And so she was grabbing what we thought was her ribs, and she was just like, not having it. Didn't want people to touch it. Didn't want people to look at it. Just wanted to be left alone. Was pissed off that her neighbor had called 911. That's
She
kind
was
of the issue.
uncomfortable though.
But she was uncomfortable.
Yeah.
And so we're trying to let the QRTs do their thing, and they're basically saying, if you want, medics are here. They can take you in, get you looked at. You may have broken a rib, or you could have done some more internal damage. We're not really sure. So, she's insistent on staying, but over the course of about 10 minutes, friend basically talks her into going. So, at this point, we're like, cool. Now we have a plan. We're going to
What
be
were
getting
vitals?
back. So we don't have vitals yet. QRTs didn't have vitals for us.
Oh.
They were in the process of into their
They
credit,
didn't want to agitate her.
they didn't want to agitate
Right.
her, and they didn't want to do anything she wasn't comfortable with.
Right.
So, they had to have permission first and all that kind of stuff.
Yep.
So we do take a quick set before we get moving towards the ambulance. And initial pressure was like right around 150 over 80. And then heart rate was normal, we'll say high 80s. And SAT was good.
Okay.
So she's also adamant about wanting to walk out to the ambulance. So she's like this old kind of frailer person. I'm like, we gotta like spot her,
Right,
kind
right.
of thing, right? Because
Oh, yeah.
we don't want her falling on us. And she's been complaining that she's just not feeling well. So get a person on each side of her, and we're walking her out, and she just folds, and she's like, she's like, there, it happened again. And we're like, what happened again? She's like, my legs gave out. I'm like, what? This is so strange, And so I'm thinking of all these, like, does she have like some weird viral illness? Like, does she have, some sort of muscular issue? All these things are running through my brain. I don't know what the heck's going on. We're all hungry. Her vital signs are stable. She's
Right.
looking a little
So-
funky though, so we're going to take her up.
So were you concerned, or do you think that maybe this is just
Honestly,
putting on a show?
the thing that was a challenge on scene was the QRTs had already been on her, and they thought she was one of the more dramatic types of people that we
okay.
go on.
Yep.
And so we were kind of led down this path of
Yep.
she's a drama queen.
Been there.
So we had that mentality taking her to the cot. Get her on the cot. She's still kind of pissed off at us and doesn't really want to be there. So we're trying to play nice and, get her loaded up, and off we go.
Yeah.
So like a good lieutenant, what do?
You
I
chart.
drive. I drive the ambulance. So,
Turn on the radio.
I make sure it's a
Keep it
nice,
down back
comfortable
there.
degree temperature in the back.
Right.
Someone has to hold the clipboard in the car.
Someone has to hold the clipboard. It's a vital.
That's what
job.
CPR stands for when
Yeah.
you're an officer. Clipboard, pen, radio.
Exactly. Holly gets it. Yeah.
And so who's in the back? You got
In
one
the back,
paramedic and one.
I got a brand new Proby medic and a seasoned medic.
Okay.
So we're a 3-medic crew that day. I got 2 medics in the back, and I'm up front. So
And she didn't. When this happened, she didn't. It wasn't like a fainting episode.
Nope, she didn't.
She
She
just
never
kinda
lost
lost- she
consciousness.
just kinda
She didn't
lost-
trip and fall.
Yeah.
She said her legs just gave out.
gave out. Okay.
So we get moving, get in the back of the ambulance, no issues, throw some lines in her, and we start heading towards the hospital. Code 1 at this point.
Mhm.
So I would say, we got 25-minute transport time, probably 5 to 7 minutes in. If you've ever been driving on a call that's code 1 that turns code 3, someone usually yells at you or pokes their head up trying to get your attention, right? And all of a sudden you got someone's face like right next to you. And so my more seasoned partner pokes his head up and he goes, "Hey, man, we got to move. I think she's dissecting." And
Really?
I go, "What?" And so I'm thinking no, could that be what this is? It's just such a strange call. None of it added up. None of
Yeah.
it made sense. And so I didn't ask him any clarifying questions at that point because it's just I know what I got to do. You got to go back there and you're busy. So
But on scene, no complaints of any pain other than the rib pain.
Other than the
I'll
rib
give you
pain.
some follow-up information that
Okay.
he got in
Okay.
the back. So we obviously start going up code 3, and for the sake of the podcast, I will just say that it was a great drive. I kept them comfortable in the back.
Oh,
There
good,
was nothing.
good job, sir.
I'm
Yeah.
sure you did.
Yeah, they felt in control in the back. They weren't getting tossed around. It was a vital part of the job of the call, and
You
I did my
probably
duty.
saved a life.
Thank you. So, we get to, the hospital, and I'll spare you some of the. I'll give you some more of that info here in a second. But the information that my partner got in the back was that she was having back pain and not rib pain. She kept putting her arm behind her along her spine, and she was on the cot, and she kept rotating back and forth, saying, "I can't get comfortable. I can't get
Oh,
comfortable."
wow.
And so my partner, who's literally had this call happen to him before, goes, "Oh my God, I know exactly what this is.
Mhm.
Last person died. This
Yep.
was a aortic dissection." So he calls it, throws another line in her, starts monitoring things a lot more closely, gives the hospital a heads up call, which was huge. And we get to, we start going up there. So, fast forward 20 minutes, and now we're at the hospital, and we're wheeling her in. And we got the monitor up kind of on the back of the gurney, and I'm at the back, and we're wheeling her in. And the route that we took was I don't know, we probably ended up wheeling her 250 feet to her actual trauma room that we got. And from the hospital, or from the back of the ambulance to the hospital bed, I'm watching the rhythm on the monitor, and it looks pretty good. We get about halfway there, and it slowed about halfway. So
Oh,
she's went from rate of 80s down to 60, and now she's in the low 40s. And then as I'm verbalizing, "Hey guys, her heart rate's slowing," she completely flatlines in the as we're wheeling her into the room.
Like in the bay.
Yeah, in the actual trauma room.
Okay.
So wheel her in, basically shout out to everybody, "Hey, she's coding," and then from there it's mass chaos, and now we're all of a sudden we're running a code. Unfortunately, she didn't make it, but the take-home point that I had from that call was one that I've had on other calls, but it's never looked 100% the same. But this one did look almost 100% the same for my partner, and so that's why he was able to spot it so quickly. But it was a really, it was just
That's
tough.
That's a tough call.
You don't know exactly what you're dealing with. You've got
Right.
all these other, external factors that are changing your perception of the patient, of what the patient's actually trying to describe but can't. And then you kind of start to put the pieces together at the very end, as she's
Yeah.
dying.
As she's dying.
Yeah.
Kind of common theme to this podcast. It feels like.
Unfortunately, yeah.
Yeah.
Those are some of the calls we learned
Yeah.
from the most, but
Oh man.
There
yeah.
is that distinctive I can't get comfortable
Yes.
type of agitation that comes with that particular presentation,
But like anatomically, like we've all done anatomy lab. Like when you look at the aorta, it's like right on top of the spine,
Right.
Yeah.
right?
It is.
Yeah.
Yep. It's like
I mean,
attached to it.
It's like, it's a retroperitoneal structure like on top of the spine. And like,
Mhm.
I think when you're like in somebody's chest looking at it, you're like, oh, yeah, no wonder their fucking back hurts.
Yeah.
Like it's on their
Right.
back,
Yeah.
Exactly.
right? So,
I had no
makes-
idea it was back there until we cut one open and
yeah,
Yeah, I saw it on a cadaver.
there it sits.
yeah,
Yep.
yeah.
Yeah.
I think in
Yeah, I've
general
seen it many times.
that agitated, and once you've seen it, like you're saying, Holly, once you see that look of like, there's something really bad going on, right? And I've also seen it with dissection,
Yeah.
where they're like agitated and it doesn't quite look right. It doesn't look like somebody who's uncomfortable from back pain, but it's like that agitation of they're dying,
Mhm.
right? And they have that kind of wide-eyed look and they can't verbalize what they're feeling, but it's not a good look
Right.
once you've seen it a couple times.
So, yeah, it was such a strange call for many reasons. But the thing that, and we talk a lot about the mentality you go into a call with
Oh, 100%.
and how quickly we can be caught off guard, right?
Uh-huh.
Because we've already made up our mind
Mhm.
before we show up about what we're going to see, who we're going to interact with. And when that is almost confirmed by your other counterparts on scene,
Yeah.
it's even that much harder to snap out of that mentality when you're treating someone. And so it was a really good eye opener for me because for me, anytime I now have a patient who's unable to describe the uncomfortable feeling, it's just like, you know what? We're not going to mess around. We're just going to take you up and get you looked at, and we'll go from there. But
Was she like clammy or sweaty, or did she have any other,
so
concerning findings? I'm just curious.
as we were wheeling her in, she went completely white.
Yeah.
She had that like see-through gray color.
Yeah.
And then she was gone from there. But en route, she was pale and just uncomfortable. And I'm sure my partner would describe her as progressively getting paler
Mm-hmm.
as time went on. But yeah,
So, Ramsey, what kind of things should we be looking for? If we have this type of call, what are some other things that can lead us down that?
Yeah, I mean your partner the back pain is kind of the classic presentation for dissection. Is,
Right.
I've got. It sounds like she had some degree of some sort of thoracic pain, right? So, I think of it sometimes as posterior chest pain, right? That kind of
Yep.
back pain that is
Yep.
sort of thoracic in nature, but people are like, my back hurts, and I mean that's sort of the classic presentation, right? Tearing chest pain through to your back. People then have, it can be pale and diaphoretic, but I think the thing that's tough with these cases is like a lot of people don't read medical textbooks,
Yeah.
right? And a lot of people don't
Right.
say those catchphrases, and a lot of these presentations they're not always textbook. So I mean the things that's hard with dissections is figuring out that they're dissecting.
Yeah.
And if you look at a lot of the statistics on it, it's like over 50% of first presentations for dissections are missed.
Jeez.
Wow.
Right. So there's a big delay in identification, which is also not great because like every hour that you're sitting on a dissection, the morbidity and mortality goes up a lot, right? But I mean, the thing that
Have
would
you ever
catch
been
my-
surprised on like we're going to do a chest x-ray because that's a pretty common thing you do. Have you ever been surprised like, oh, it's a dissection, or
I mean,
um,
yes, like
found it that way?
there's I've had maybe a couple cases through even back into residency where you get a chest x-ray and you're like, ooh, that mediastinum looks wide, right? And it's not what you're expecting. Then you get a CT and they're dissecting, but I'd say that's more rare, right? If you have any clinical suspicion, you get a CTA. And I think the thing that's tough with this, especially this case, is that the legs giving out, the whole story, her sort of being resistant to care, like she wasn't telling you about the back pain. And people come in with back pain, right? All the time.
Uh-huh.
It's a hard balance because you can't like CTA everybody that comes in with a degree of back pain. But
how quick is a CTA? Like from the time you order one in your software to the time that you get the results back, what's the typical?
I mean, tough question, right? If let's just say you can get the patient back to the scanner, pretty quick, 10 minutes.
Okay.
To get him back, get him contrast studied, get him back to the room, get the images up. Yeah, maybe like 10 to 20 minutes. And
are you putting a rush on those? Is that a thing?
yes.
Okay.
Yeah. I mean, if you have a high suspicion for this, I had one the other day. at Emmanuel where, the guy gave a very classic story, chest pain, through to the back. He looked like crap. He was agitated. He was sweaty. I was like, this guy's dissecting.
Yeah.
Right. But this is kind of that's sort of more rare. And he was dissecting. So, yeah, I called radiology. I said, hey, I've got this guy's, I think he's got a dissection. Like, we got to get him studied like now.
Yeah.
And so it was pretty quick. And I looked at it and it looked like a dissection. And so I called CT surgery in, and
How'd he do?
he did okay because he had a descending dissection. So he had a type B, not in the ascending aorta. So those ones you actually don't typically take to the OR emergently. And they
Can you go over those two?
Yeah, so I mean, we used to, and I always look it up because there used to be an old DeBakey classification for dissections, which was like 1 through 3. Now we use what's called a Stanford A and B, right? And a type A dissection is anything that involves the aortic arch, right? So it can be the aortic arch beyond the arch down into the descending aorta, or just the arch. And then a type B is anything external to the arch, so just the descending aorta.
Okay.
And the reason it's a big issue is that the type A's, you're talking to usually a cardiothoracic surgeon, and sometimes they do joint cases like CT surgery and vascular surgery, and those tend to be surgical. Like you're going to the OR, they're getting a big chunk of their aorta cut out and a big graft or whatever.
Right.
Whereas the type B's tend to just be blood pressure monitoring, ICU, vascular surgery, plus or minus surgery, but you don't usually rush them back to the OR.
Gotcha.
Yeah. And those don't tend to dissect back into the pericardium,
Mhm.
which is why a lot of these people die, right?
Right.
They dissect back into the pericardium, get tamponade, and die from tamponade.
Do they present the same way?
Yeah, I'd say we see less type A's because I think a lot of people don't make it to hospital.
Right.
But yeah, I mean, the presentation's still that sort of tearing, radiating back pain,
Okay.
right? It's kind of the big.
We had another one. You're bringing up the type A's. We had again. It's a weird setup. Our hospital system. We have our level 2 trauma center, but then we also have like in the same kind of general vicinity of this medical complex, there is a immediate care center.
Okay.
And so a lot of times the people whose first due is the hospital end up taking patients from immediate care to the ER because they went to the wrong spot, right? Or they found something and it's like, we got to get you looked at. And so was working in that district that day. This is probably 10 years ago now. Get called for chest pain, which is a very common thing we go to this facility for. And people think, I don't really want to go to the ER. I'll just go to immediate care and just get this checked out. And then they get there and they realize doctors and nurses don't mess around with chest pain. So you get a bunch of stuff rolling. And this guy's gray, looks like crap, feels like crap, very sweaty, has pain in the center of his chest. And we walk in and it's one of those things you're like, ooh, this guy's not feeling really good. I feel kind of bad for the dude. He was in his late 40s.
Oh, yeah.
And heavy smoker, really out of shape.
Yeah.
Just looked like he looked like he was having an MI to me. And so we are talking to him, kind of getting the story from the docs. And I would say we'd been there maybe 3 minutes. And this nurse is sprinting down the hallway and we can hear her. And then all of a sudden she's there in the doorway. And she stares at the doc that had ordered the test, and she goes, he has a 7.5 centimeter tear in his aorta.
Wow.
And
they ran back from this from CT.
They ran back from
Yeah,
CT
yeah.
and gave this information to the doc. And everybody kind of goes, huh? Like, what? And so all of a sudden, our attention shifts to this guy like, we're about to watch you die. It was really strange kind of slow-mo. So we very cautiously, get him on our cot. And we're trying our absolute best not to hit even the slightest, awkwardness in the, concrete going out to the ambulance. Because we have like a quarter-mile drive to our ER. They call ahead, get an OR prepped.
The longest quarter mile.
Yeah, yeah, no kidding. Wheel him in. They get him prepped, and as we're getting our gurney out of the prep area and we're wheeling down the hall, we hear massive transfusion,
Oh,
OR3, and we're like,
Mhm.
we were just in OR3, So
Yeah.
he ended up not making it either. But yeah, it was one of those. It's hard to say, especially with the limited tools that we have. It was the dude looked like he was having the big one, and I guess he kind of was in a
Yeah.
way. But very strange.
Well, I think that's a tough thing with these is that a lot of processes like MIs and STEMIs or any sort of occlusive coronary incident can, people have chest pain and they're sweaty and they can say they have some radiation to their back or,
Yeah.
or I think dissections and PEs as like an ER doc are the things where you're like, God, they're kind of sneaky,
Mm-hmm.
right? And they're big deal misses and they're tough. Like pre-hos, I can't even imagine we have so many other tools once they're in the ER
Mm-hmm.
that we can utilize, right? In like a pre-hospital setting, I think it's even harder.
Yeah.
Be like, oh, this guy's dissecting,
Well, and so much of what we do is what we've seen on other calls, and we're looking for
Yeah.
trends and
Yeah.
we're looking for patterns, and when we see those, we run with that because it burned us one time.
Right.
And we don't want to let it happen again.
Right.
And so I know
That's
that's
like the art
obviously
of being a paramedic.
yeah, and that's obviously true in all of medicine, right? Like that to some degree is going to happen, but because we're so limited in what we can actually do, for patients in the field, we rely on that,
Right.
That sense more that, Dan always calls it his spidey senses, which is basically just your experience talking to you, that something's not right.
Which is why like the paramedic discretion for trauma injuries,
Yeah,
it
that's
tends
huge.
to be
Huge.
like the best generator of an actual problem
Yeah.
is your discretion.
This patient does
that
not fit
art
the
of-
usual.
But something's going on, right? I
Yeah.
can't pinpoint it.
Yeah.
We had a great activation the other day that was, EMS discretion, and lady did not meet at all. And initially, people were kind of like, yeah,
Stupid
probably another
paramedics.
trauma, and she had a big brain bleed and
Oh,
went to
wow.
went to the ICU, and yeah. So no, I think spidey senses are important.
Absolutely.
Yeah.
Holly, you also had a great incident with aortic dissection. Do you want to walk us through that one?
Sure. I think on the flight side of things, we probably transport the most aortic dissections. At least
Yeah.
we know they're dissections when we're transporting them. Sometimes it's a scene call and you might think it's a dissection, but we frequently would transport from hospital to hospital a known dissection, which is kind of scary sometimes. I know that in the field, let's say if you know it's a dissection, you probably have like labetalol or some sort of beta blocker to treat with. Treating for pain is super important because pain can increase your blood pressure. And in these patients, we want the blood pressure to be as low as possible.
Mm-hmm.
We want their heart rate to be as low as possible. So our go-to med for aortic dissection is esmolol for the, at least for the flight transport world. And then if esmolol isn't working, or if for some reason they have pulmonary edema or something that precludes them from getting esmolol, then we would use clobetasol, which is, it looks like propofol, but it's definitely one of those meds you can turn off and on. And just like esmolol, you turn it off and on and it immediately stops working.
It's super
But that
good.
was, yeah. And for us, that was like the major thing is keeping their heart rate like between 60 and 80 and their systolic, between 90 and 100 or 110, and just really trying to titrate the esmolol to that effect.
Mm-hmm. Yeah, and we use
and
we
I
use
think,
less clobetasol, and we use a lot of nicardipine. But
right.
again,
Mhm. I think a lot of
turns on and
ERs
off.
still use nicardipine.
Yeah.
Yep. We would see a lot of people, like a lot of maybe rural places, not know how to dose the esmolol well. Like they would start the maintenance infusion without the loading dose, which is really important to have because you're bolusing and increasing the titration like step by step to, get the effect you need. So, but we did have a person that we picked up in a rural place. I think by ground, it was an hour to the facility that was accepting her. And she was a younger lady, probably in her 50s. with a dissection, which was surprising to them because she presented like most women do, just not feeling well, sort of like mid back pain. But she was, for all intents and purposes, totally stable. She was alert and oriented. She was making jokes. She begged us to not take her in the helicopter. And so we, of course, convinced her to go. So we have to drive from the hospital to the helicopter where it's parked. So it wasn't a hospital that had a helipad. So we get her over to
what's the time frame there?
It's about 7 minutes, probably. Dan, was I with you on this call? Do you remember? Maybe it wasn't you. I don't remember who I was with, but we finally convince her that the helicopter's safe, and we get her in there, and we're getting ready to go, and we get a chip light, which means when you try to start the helicopter, if there's any like floating metal pieces around, it triggers the chip light. And so we do have a protocol for that, but you're not allowed to just burn a chip light and then restart it and keep going because of the specific helicopter we had. The fix for that is to have someone from maintenance come out and do a full inspection, and then you can go.
Super
so that would have been like a
time-consuming.
4-hour
Yeah.
process, right?
Jeez Louise.
Not what we want. So we have her on our one bag of Esmolol that we own, which, as we've calculated, is probably going to last us about an hour. Our transport is now an hour because now we have to unload her and put her in an ambulance and drive to the hospital, where she's a direct admit to the OR. So, of course, have you ever been on a rural road that's not super bumpy?
No, they don't exist.
This one was like, multiply that by 10, and it was just.
Had the imaging already all been,
No
everything had been
idea.
done? Like they knew that it was a dissection. They knew it. Was it a
We
type
knew
A?
it was a dissection.
Yeah.
It was a type A. She was
Okay.
going directly to the OR, and we were just trying to. And so she had a major anxiety anyway. But she was very happy to not fly in the helicopter. She was very happy to go in the ambulance. So,
And it had
Anyway,
her
long
symptoms
story
changed?
what was that?
Had her symptoms changed, or are they still staying the same?
It's still staying the same.
Okay.
I mean, she is currently having pain. She is, like I said, she's mentally with it. She is stable in that way, but it's kind of touch and go, like we're having a hard time keeping her blood pressure down. So we ended up adding clofidipine onto the max amount of Esmolol just to keep her blood pressure within a range we were happy about. And so anyway, we finally get to OHSU. We're backing into the ER bay, and the pump starts beeping because the Esmolol's out.
Dang.
And we've maxed our clofidipine, and we've maxed our Esmolol at this point. So I'm like, okay. So I called the OR to let them know. So we arrive in the OR, and no one's there. I don't know where everybody is.
Oh,
And like,
What?
we have an active dissection, and we're out of Esmolol. So I'm freaking out a little bit, but of course they were all calm, cool, and collected, and getting consent, and taking their time. And anyway, it was kind of crazy. So
She made it?
I do think if we didn't, she did.
Oh,
Yeah,
yeah.
she actually had a
Nice.
great outcome.
Look at this. Positive.
oh, thank
Yeah.
you.
Huh. Man.
Steve's been ringing me down this whole time.
Yeah. Gotta have something to bring us back up. Jeez Louise. Goodness.
And there's a lot that goes into that one. That was kind of embarrassing. First of all, that the helicopter didn't
Oh,
turn back on.
yes.
Right after you're trying to
Um,
convince her that it's safe.
Yeah.
Yeah, this is safe.
It was-
Trust me.
It could have been a sitcom for sure. But yeah, so we ended up getting her there in time, but that doesn't always happen. I've never had to max out both of our.
Yeah, that's amazing. You went that far.
Yeah, and Esmolol is interesting because it blocks like epi and norepi, the like naturally occurring epi and norepi in your body, and so it does kind of help you stay chill.
Mhm.
In that way, but it is the type of medication that when it turns off, it's gone.
It's
like,
done.
It doesn't
Yep.
last.
Yeah.
Yep. So we were.
Well, it's great you guys
but
start
I'm
that
really glad we
because-
had all of those things to be able to manage the patient with, because without it, she obviously would have continued to dissect and
Right.
probably wouldn't have made it.
And most people will tell you, like a lot of people will start clofazepine or nicardipine, focusing on the blood pressure, but then you get a reflex tachycardia, and
Yep.
which is a problem when you're dissecting, because then you increase all these shear forces and everything gets worse. So it's super important to get the heart rate
And
down.
pain management.
Yeah, pain management, esmolol, if you need nicardipine or clofazepine, whatever you have for you guys, and route, obviously.
We were giving her fentanyl and Ativan, and like she got the full cocktail.
Yeah.
So she was real happy.
Yeah, and what was do you remember what her presentation was? It was just, you said it
Her
was just kind of
presentation
vague.
it was like vague, sort of like mid back pain. It had been going on for a while, but she didn't want to. But she was at work,
Yeah,
and she didn't want to like leave work early, that kind of thing. She was a tough lady,
yeah,
and I think reverse roles. I think her husband made her come in because she wasn't, again, she was uncomfortable. She couldn't quite sit on the bed she wasn't still at all. She was constantly moving around, just trying to get comfortable.
that's great. And the one
So
I had
they
in
did
that
a good
story
job.
is similar to that. And actually, I had we talked about it briefly, but she got called on. I forgot this part of it. She got called on by EMS the night before.
Oh, no kidding.
Oh.
Yeah, and they kind of. So I had a lady that.
Yeah, give us the
backstory
background on
is-
this one. This is a good
The
one, too.
background is, from what I understand, EMS got called the night before I saw her. She was short of breath. So I think somebody in her family was worried. They called 911. She, I think, refused transport. They kind of chalked it up to her being really anxious. They kept her at home. This is also in the height of the pandemic. So this is like
Right.
Okay.
Nobody
like
wants to go.
COVID, when COVID was at its worst,
Yeah.
right? So she comes in the next day when I'm working in a critical access rural hospital, single coverage, busy shift, midst of COVID.
Right.
She gets transported because she can't breathe, right? She gets put into our COVID room, which is like this back triage room
Yeah.
where
Yeah.
people go to die.
Yeah.
Just like
Right.
like kind of on its own. And I'm running around. I end up going back there because they couldn't get a line on her, and they're like, we're not sure if this blood pressure is accurate. Hey, will you come see this patient? We think she has COVID. Her SATs aren't great. She can't breathe. So I take my ultrasound back there, throw a couple of IVs in her real quick, listen to her lungs, and I'm like, God, her lungs sound fine.
Yeah.
They're pretty clear. But she had that look we're talking about, where she's like leaning forward and leaning back and like can't get comfortable. And I'm like, what is going on? And she's like, she had no pain. She's like, I can't breathe. I can't breathe. She just kept saying, I can't breathe.
Wow.
And I'm like, God, her lungs sound fine. Like, this is weird. And I, serendipitously, like, just happened to be back there with an ultrasound because she's
Right.
difficult to access. I'm like, I want to look at her heart and her lungs. I stick my probe on her heart, just giant pericardial effusion
Jeez.
in like in the most borderline of Tampa. I mean, she was in Tamponade effectively. Like,
Yep.
she had cardio. So I'm like, get her to her. I like literally poke my head out of the side of this room, and I'm like yelling, like, activate life flight. This lady's in Tamponade. Get her in another room. So we like wheel her to this other room, and I put an art line in her, and her pressures were super borderline, like 90s systolic,
Mhm.
still mentating. It was actually St. V's, I think, in Portland on the Horn, and we don't have kits. We don't have pericardiocentesis kits. Her pressures were still okay. She was still mentating. I mean, long story short, they were like, get her to Portland now, right? Flyer.
Wow.
I'm like, well,
Cross your fingers.
I could put a central line in her pericardium under ultrasound. They're like, oh no, don't do that, don't do that. What are you talking? What kind of cowboy medicine are you talking about? I was like, that's our
We're
only
thinking
option,
outside the
right?
box, man.
Yeah, and I was real worried about her, and then life flight she's like too unstable to fly.
Yeah.
They got there. I'm like, well, she's gonna die. So we get another
Right.
doc on the helicopter with them, and she ended up coding en route. They did a pericardiocentesis, but she didn't make it. So I'll bring us back down since
Okay.
Holly had
Thank
a
you.
positive case.
Yeah.
I think it's
Thank
good.
you for bringing us
Yeah,
back to
I think it's
reality.
always good to end on a
Yeah.
on a
Probably,
downer.
I mean, the moral of the story is if I was on the flight, it probably would have turned
It
out.
probably would have turned out.
Absolutely.
Yep. Yeah, for sure. I mean, these cases are tough and they present weird.
They are.
And they're not, the outcomes are,
Mm-hmm.
if they're good, they're lucky.
Yeah.
Right.
One thing I wanted to mention, which we haven't really brought up, which is kind of like the one thing they tell us to do in EMS, is the blood pressure differentials. So checking on the right side, then checking on the left,
Yeah.
and we're looking for that. Was it greater than 20 points?
Yeah.
So can you walk us through why that's important? What the heck that signifies?
Yeah, I mean, when you're and Holly, you can probably jump in too. But when you have, and some people in the ICU will even put, well, there's an ICU doc at OHSU who's like this super brainiac, famous guy. I've seen him put in 4 art lines.
Wow.
So both upper and both lower
Wow.
extremities for dissecting patients.
Is that right?
Yeah, and then you like titrate your blood pressure to the highest one, but yeah, if you're dissecting,
It's like a video game at that point. What are you doing over there?
as that dissection travels down that lumen of your aorta, it can knock out your renal arteries. It knocks out all those little branches off of your aorta, so you can get all these blood pressure variations on each side of your body, right? So
Yeah.
If somebody came in with a big blood pressure variation like that and chest pain, like that's another big red flag, other than the story, right? But that's a good point. For people that you're worried about, like you should always be getting blood pressure, bilateral blood pressures.
Right.
Yeah.
And that's kind of like in the trauma settings and things like that, that's usually pretty standard. We always get both sides.
Yeah.
Yeah, I mean, it's just one more tool
Yeah.
in the toolbox you have to add to the story.
Right.
Yeah.
Do you guys happen to remember if you guys noticed any blood pressure differentials in your patients that we've talked about?
The one I had, I think the blood pressures were both kind of crappy.
Yeah.
Kind of borderline.
Yeah.
Yeah. And then I don't know for certain because she was so unstable that we couldn't image her or anything like that. But after talking to cardiology, we kind of debriefed on the case. They're like, she probably had a type A dissection. She probably dissected back into her pericardium because it was pretty quick, and it, she had some clot in her pericardium. It sounds like when they kind of saw her and did an echo, and chances of survival of that when you're transporting from a rural hospital, like our transport time, it's pretty, like, even if you got a line in her, like they're just going to keep bleeding into their pericardium. And
Right.
Oh yeah, and there's no space in there to bleed either. So I
Right.
mean, unless you can evacuate it,
yeah,
and that's been taken out of protocols. I mean, some places still have that in their protocol, but I mean, let's be honest, nobody's good at it, and who wants to actually stick a giant needle in someone's heart without
Yeah,
ultrasound
Right.
Yeah.
We did it
in
on
a
a pig lab
bumpy?
once,
in a
and that
Bombay
was
Yeah.
it.
helicopter.
Yeah.
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 My takeaway from this is I hear you guys talking about all these different signs and symptoms that, it's the end of shift. I'm tired.
Mhm.
I've already been in this patient 6 times in the last month, and
Yep.
I just blow it off.
Yeah. Every call,
Yeah.
man.
Uh-huh.
It's
Gotta-
got to be, if it's not on your radar, you're going to miss it.
Yeah.
Yeah.
Right. Unless, every once in a while somebody presents with that like
Classic, right?
Mhm.
presentation. But like that, when you're working in the real world, like almost nobody comes in with classic
Right.
presentations. Every once in a while, if you're lucky, but most of the time you got to work at it.
Yeah.
You know?
I was pretty impressed with my buddy.
Yeah.
The fact he caught it, obviously it didn't change the outcome, but he knew what he was dealing with at that point, and he was able to bypass all of the, extraneous information he was given, and then form his own opinion
Nice.
after we were transporting. So
And he's a grumpy driver, isn't he?
no, I was the grumpy driver.
No, the grumpy driver, the fire engine normally.
Normally, yes.
Yeah.
Yeah, that's a
engineer.
great catch.
Yeah.
Yeah, because that was a weird case.
Yeah, very weird. Well, guys, that's all we got for our episode. Is there anything else?
That's a
you
good one.
Want to share? Anything else on your brains?
Holly usually has
Trust your
some
gut.
really smart.
Trust your
things
gut.
to say.
She does.
She does. Yeah.
Yeah,
Trust
I
your gut.
you do, as much as we all try to practice like evidence-based medicine and follow protocols and algorithms and clinical guidelines, like there is that like part of you that's like this feels different, right? And I think that people in EMS, emergency medicine settings like that it's a really important thing to trust.
Yep.
Because sometimes your gut
Yeah.
tells you to do something that is maybe not, evidence-based, or that, you don't need to, if you plug it into some risk calculator, maybe you don't need to do a CTA on this person for a PE or a dissection. But every once in a while, you're like, something's up.
Mhm.
And I think it's important to like,
Yeah. And from your end, you have a lot of pressure on you from both, probably from a lot of places where you have to have a very solid reason to do a CTA or like a very expensive procedure, right? You can't
Right.
just I mean, I'm sure you'd love to do like 10 times more CTAs than you do,
Sure.
but you're under a lot of pressure to not do them unnecessarily. And I don't know if they keep track of them or if, there's any pushback, but you have to have a strong clinical indication to do the thing that's going to tell you the yes or no. So there is a lot of, not guesswork, but there's a lot of probably talking yourself in and out of different procedures
Oh, 100%.
Yeah.
as you go.
Awesome. Well, let's leave it there, guys. Thank you so much for your perspectives and for making me feel better about not always catching these things. Really appreciate all your guys' input. But yeah, something to keep on your guys' radar. And we've got some fun episodes coming up. So we'll catch you on the next one.
Sounds good.
Thanks, Steve.
Thank
Cool.
you.